Hello and welcome to the Feeling Good podcast. I am your host, Fabrice Nye, and joining me here in the Murrieta studios is Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new TEAM therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. Welcome to episode 101 of the Feeling Good podcast. Today we're going to do another Ask David. It's been a while since we did that, I think. And I'm not even sure because I've been gone for over 3 weeks. And even though we've been publishing the podcast at regular weekly intervals, I was just way off in Europe. And you, David, were also doing some traveling, weren't you?
Absolutely. And I want to say that I missed you a lot in the last few weeks, and it's just so great to have you back.
Same here.
And I was up in Whistler, Canada, doing my summer intensive, which was tremendous, by the way. We did a live demo, we got a video of it, and it was just very dramatic. And I'm hoping we can get permission to turn it into a teaching program.
That'd be great,
of some kind. But everywhere I went, people were asking about Fabrice. So I think you have a growing fan base worldwide.
Great. So I think today we're just going to use one listener's email because he's making 3 different points in there, and I think that would be a nice tight package to focus on this. This is somebody who is interested in REBT, which stands for Rational Emotive Behavioral Therapy. This is the late Albert Ellis's brainchild, and this is from JM, and here's what he writes to you. He says, I recently watched a podcast episode on REBT that very briefly criticized your TEAM approach to therapy. I was wondering if you would like to comment on it. It's only 13 minutes, and he gives a YouTube link, which we'll put in the show notes.
Sure.
And some issues that were brought up, and the first issue is about testing, the second is about empathy, and the third is about agenda setting. So it's quite in a neat order. So I'm going to ask you the questions one at a time and see what your response is to those criticisms.
Sure.
So here's the first one. Testing clients is pointless since you can simply ask them how they are doing and how you are doing. And if they keep returning, you are doing okay. You, David, are not for a, quote, common sense approach to therapy, but need to, quote, dress it up with all sorts of tests to make it look more authoritative. Testing makes therapy feel too clinical and impersonal, however.
Well, those are really, really important points. All 3 of the points that you raised, they're intellectually challenging, but also practical from a therapeutic point of view. As you know, Fabrice, in TEAM, we test patients in the waiting room before the session begins, and again in the waiting room after the session is over. And we're asking the patient, how are you feeling right now in terms of depression, suicidal urges, anger, anxiety, and that way, by looking at the before and end of session ratings, you can see how much your patient has improved, or if your patient has improved. And it's like having an emotional X-ray machine for the first time. And in addition, the patient will rate the therapist at the end of the session, as you know, on empathy, on warmth, on understanding, on helpfulness, and other dimensions. A lot of therapists don't use testing like the 2 here, Dr. Michael Edelstein and Tommy Bateman, and are of the idea that it's not valuable, or even desirable. I did a study at the Stanford inpatient unit to see how accurate therapist perceptions were of patients, because most therapists have the idea that I kind of know how my patients are feeling, and I don't need to do some kind of bean counting with psychological tests to know my patients. And in the study, I had 178 consecutively admitted inpatients complete my Easy Diagnostic Survey, which is a self-assessment tests that patients can take on their own and hand to the therapist, and in 5 minutes you can pretty accurately diagnose, if you're so inclined, the 50 most common DSM diagnoses without having to do a timely or time-consuming interview.
Yeah.
And as a part of that, half of those patients had to be interviewed by experts in using something called the SCIDS diagnostic interview. It's a scheduled interview that you go through 3 or 4 hours asking them about depression and all the patient's symptoms. At the end of that time, I did a little additional study that the people in the study weren't aware that I would, of the purpose, but I gave both the patient and the expert, who had just spent 3 or 4 hours talking to this patient about his or her feelings, my brief mood survey, the same one we use in therapy sessions. And asked them to turn their backs to each other, and the patient fills out, how are you feeling right now? How depressed are you? How anxious are you? How angry are you? How suicidal? And then the experts were instructed to guess the patient's answers. Since you've just been spending 2 or 3 hours with this patient talking only about the patient's feelings, what is your understanding now of how that patient is feeling at this moment? In addition, the patients rated these experts on how warm and helpful that they'd been, gave how empathic they were, how trustworthy they were, and how helpful they were. And again, the experts rated how they thought they came across to the patients using the exact same scales.
Yeah.
And then I was able to put all the data in a database, look at the correlations between the two, and easily calculate the experts' accuracy.
Yeah.
How accurate are we? And the data was pretty shocking from 2 or 3 points of view. First, the accuracy of everything was exceptionally low. The expert's accuracy at sensing changes in the patient's depression was 3%.
Right.
The ability to perceive suicidal urges was 0%. The accuracy at knowing how angry the patients were was 0%.
And knowing that 100% means they know exactly what the patients
yeah, and 0% would be you have your perceptions
it's random chance,
just totally random. And then the accuracy on helpfulness, how helpful was 0%. So what this is showing us that the way the therapist is coming across to the patient and the therapist's belief about that are totally different universes. The only thing, the highest rated one was empathy, and that was only 99%, just 9%.
Yeah.
So on everything, the experts were more than 90% off base. And so the question you would have to ask yourself is it desirable for therapists to know how patients feel? You see, the other mind-blowing thing is that therapists like these two, Dr. Edelston and Bateman, think they don't need this because therapists believe that they know how patients are feeling.
Well, in there he says, you can ask the patient, how are you doing? So what's wrong with that?
Well, have you ever been to a restaurant that wasn't very good? And at the end, the wait person comes up and says, how is everything? And what do you say?
Fine.
Yeah, fine. So you can't get the information verbally because of the power imbalance and the social desirability. But for some reason, when patients fill out the scale at the end of the session, they tend to be amazingly honest. And for example,
what's the difference? Because you still have the same power imbalance. They know that they're going to turn it into you. So what's different about that?
I haven't done any research on that. It just seems to be the case. For example, when, if you say to the patient, how's everything going? The patient says, fine. But therapists who use the scales in clinical settings, their own clinical work for the first time. I say, try the scales out with the next 30 patients you see, and then tell me how your scores were. And almost every therapist gets failing grades on empathy and helpfulness from every patient at every session. Mm-hmm. And so the problem isn't that the patients aren't honest in the way they fill out the scale. The question is they are honest, and can the therapist take the heat? But so what I would say respectfully to Doctors Edelstein and Bateman, if it were the case that your perceptions of your patients were extremely inaccurate, but you didn't know that, would it further your cause to have that knowledge, exactly how depressed, how anxious? The experts say that 10 to 15% of chronically depressed patients will commit suicide if they're receiving treatment and medications both. So that means that if you're treating chronically depressed patients, as my practice, almost everyone was chronically depressed, that you're going to have a lot of suicidal patients, a lot of suicide attempts. Yeah. And the main reason patients make suicide attempts is that the doctor didn't know the patient was suicidal that day. You just can't tell, but they will report it. And you'll see that on the brief mood survey, how suicidal they are at the beginning of the session and how suicidal they are at the end. And if they're suicidal, you can intervene and nearly always save their life. So it's my own point of view that you can't do good therapy, much less world-class therapy, without the kind of information you get from the testing, and that it doesn't make the therapy indifferent. It makes the therapy tender, human, and real, because the patient has an avenue to share his or her feelings with you and let you know the things you've done or said that turn the patient off, and then you can process those things and develop a deeper therapeutic relationship. I think there's an increasing body of literature, we'll leave that to another day as well, that's confirming that when you have information about how your patients are doing on a session-by-session basis, it leads to a measurable improvement in outcomes. And I think that's been the whole basis of team therapy. I'm seeing recoveries in my patients now at speeds I would have thought impossible 10 years ago or 20 years ago. It's been a night and day change, and it's because of this new approach to testing. Your patients can be your greatest teachers, your best teachers by far, if you give them the opportunity. But I would have to say that this requires courage on the part of the therapist. And some therapists, if they're narcissistic and want to believe they're experts, then they definitely will fight hard against the testing, because it requires humility to want to see how your patients are really feeling and how they feel about you. Maybe just one brief thing we could do here quickly. Remember when we used to hike, when you first came to TEAM? Yeah. You remember how opposed you were to testing?
Oh, I remember, yes.
And tell us, what are your thoughts about this?
Well, since that was a required condition for me to stay in the training, I finally did it. And one thing that I said to you was that I was convinced that my clients would balk at the idea, because I had some people who had been working with me for a while. And your suggestion was to say, well, we can try this and see how it goes. And if you don't like it, we don't have to continue. And not one of my clients blinked an eye at it. It's like, oh, sure, why not?
Yeah, right, exactly.
And I started using that, and I have to say that for me, it has one very specific benefit, which is the client comes in, they come from their life and they're busy thinking about this and that. And then they come into the waiting room and they take a moment, just doesn't take more than 5 minutes, for them to think about, oh, how am I feeling right now? And they start to introspect, and they're ready and prime when they come into the therapy room. And then we can look at, it looks like, you're really anxious today, and And I can say, well, tell me more about that. And so I have an in directly as opposed to, well, how was your day? And they tell me about their entire week and the 45 minutes are gone.
Yeah, absolutely. One last thing, one of the things that really sold me on testing, I was treating this attractive young, physically fit woman who was a prominent business executive in Philadelphia. And I was kind of in the days I wasn't sure, I don't need to test all my patients. And she'd been horribly depressed at the beginning of therapy, and she was very perfectionistic, and she just loved the sessions, and she really liked me, and I could just see we're doing great. She did copious amounts of psychotherapy homework, and then around the 8th or 9th session, I could see that she was pretty much recovered. She was joking and laughing and happy, and I thought, well, why don't I get another score here on the depression test, and maybe I could present this case in a workshop to show in like 8 sessions you can move someone from severe depression to complete elimination of sessions. And I remember at the time I was using the Beck test. I have other better tests, as you know, that I'm using now, but that one from 0 to 63. There are 21 items, 64, I think. Is that right? 21 items?
I don't know.
0 to 3.
I haven't used it in a while, yeah.
Something like that. At any rate, she was near the top of the scale. So it's one of the worst I'd ever seen. And I thought, well, would you mind filling it out again today? Because I could see she was happy and feeling great. And she filled it out, and her score had actually worsened and was almost at the highest possible score I'd ever seen.
Yeah.
And I said to her, this is shocking to me, because I've enjoyed working with you too, and you're doing beautiful homework on your perfectionism and all of this stuff. You're getting over it. But the point isn't to be doing psychotherapy homework and, getting over perfectionism. The purpose is to change your life. And I haven't done anything for you at all. And, I must be missing something. And then there's this long silence, and she didn't say anything, and then she became tearful, and she said, Dr. Burns, I don't know if I'm allowed to tell you this or not. I feel like I'm betraying a family secret, but when I was little, my parents used to fight terribly, and it terrified me, it scared me, and I would run into my bedroom and hide, and then my father would come shouting into my bedroom, and he would pick me up, and she was kind of small and petite, I could imagine picking her up, and he would slam me against the wall, throw me against the wall, and I'd fall, and then he'd pick me up and throw me against another wall. And then she started sobbing and just saying, I just feel like worthless, and I feel ashamed of telling you just now because I'm betraying a family secret. And then I suddenly saw that she wasn't the way I had thought at all. And the next few sessions, we kept doing much the same kind of thing that we'd done, looking at her negative thoughts, talking back to them, but there was a whole different feel to the therapy. And 3 more sessions, her score had dropped down to 0 on the Beck, and Beck test, she was truly joyful and recovered from depression. But without the measurement, I would have completely missed the boat. So Michael Edelstein, if you're listening, and Tommy Bateman, maybe you try it out sometime and let me know, see what you think. I'm also a little awkward being in debate with REBT, because, REBT, I feel, is my brother type of thing.
Yeah.
And Albert Ellis was just I was such a big fan of Dr. Ellis, and he was a tremendous supporter of my work. But one thing I loved about him, he was very open-minded to new ideas, including ideas which challenged his own thinking, which brings us to the second criticism, which is empathy.
So, before you move on to that, I want to refer our listeners back to our episode number 2, which is called Testing, a Boring Topic with Exciting Implications.
Good memory. Wow. Awesome. Thank you.
So, yes.
We'll link to that one too.
So here's the second point that JM is making. Empathy is not important. Clients pay good money to therapists to get their help, not to feel validated or anything else. Self-help books couldn't even work if empathy was important. And your book Feeling Good has actually been given to people who were depressed who got better.
Yes. And by the way, I believe the empathy of my book Feeling Good is far superior to my own. It is a very empathic book. And when people read it, they say, "Oh, Dr. Burns, when I read your book, I felt like you were talking to me, and you're the first person who ever understood."
So they even use your point against you by saying that since most therapists are not good at reading how empathic they come across to their clients, that should not be a focus.
Yeah. Well, great point. And these are, extremely important things in the field. I was so excited about this, and I think there's some truth in what Tommy and Michael are saying, and perhaps some error as well. Carl Rogers tried to sell us on the idea that empathy was the necessary and sufficient condition for personality change, for recovery in depression.
And maybe if you're Carl Rogers, that's true, but nobody has been able to replicate it since.
Exactly. No one else could get the kind of results he got. And then Albert Ellis, who I love, the guy who was so kind and so honest, he was a tremendous contributor. He came along and said, Beck then came along and said, "Carl Rogers, you're wrong. Empathy is not the necessary and sufficient condition. It's necessary, but it's not sufficient. We need cognitive therapy and all this other stuff." And then Ellis came along and says, "No, you're both wrong. Empathy is not necessary, and it's not sufficient, and it's not even desirable. Because if you're real warm and caring, the patient will just come and get addicted to you, dependent on you.
Yeah.
They got to do their effing homework to get better, and the less empathy, the better."
Yeah.
And so I did the first, and to my way of thinking, only pretty sure research study in the world literature that ever looked at the causal effect of empathy on recovery from depression, while at the same time looking at the causal effect of recovery from depression on empathy and the quality of the therapeutic relationship. And the data showed, and we've talked about this on a hike, that there is indeed a direct causal effect of empathy on recovery from depression. If you're warm and caring, there will be a mood improvement in your patient. But the sad thing is that the quality, or the quantity of improvement, the amount of improvement is only modest. You can get rid of at most a third of depression, the severity of depression, with therapeutic empathy. And after that, you're going to need techniques and methods to change the way your patient thinks and feels. And so you guys are right in that sense that empathy is not the strongest tool in therapy. But I believe it is necessary, because I think trust and warmth and caring are necessary to use the kinds of powerful tools that we've developed in team therapy. And I know that REBT has a lot of powerful tools too, thanks to Albert Ellis. Well, I presented this. I was asked to present in his honor at a conference in Colorado years ago. They had something in honor of his such and such birthday or something. He was there. And they asked me to present my work, and I mentioned this study, and Ellis says, you've convinced me, and I believe now that empathy really is important, and you've proved it with your research. That's one of the things I just loved about him. He was such an open and honest person, and he didn't steal from other people the way some of the leaders in our field have sometimes done.
Yeah. Okay, and here's the third point that JM is making. Resistance isn't a problem, since clients come to therapy for help, and if they don't get the help they want, they can simply go elsewhere. They want to give as much power to the client of therapy and away from any coercion by the therapist. So,
do you want to comment on that one? That's so mind-boggling, I hardly know where to start.
Well, we would have to maybe get the actual wording they use in the video. Yeah. This is what was transcribed by our listener here. But
well, let me say that we used to think that way too. The patient is coming to therapy, therefore they must want to get better.
I mean, that's the assumption.
That's the assumption,
but it's an incorrect assumption.
Yeah, that's right. Because we all have mixed feelings about change.
Yeah.
We have part of us that wants to lose weight or stop drinking or get out of the depression or end our panic attacks. And then there's a part of us that kind of fights and resists. And the greatest cause of failure in therapy is a pushy therapist who's trying to persuade or help the patient to change, because that fires up the patient's resistance. And if you look at the outcome studies of all the forms of therapy, REBT, the Beckian version of cognitive therapy, every single form of psychotherapy for depression, none of them is hardly any better than placebo. None of them are getting more than a 50% improvement rate in patients, and the definition of improvement is very modest. So they're a little better than placebo, but hardly at all. And the reason for that is because therapists, for the most part, are not taking into account resistance. And what we've done in team therapy is developed tremendous, you call them resistance busting techniques or resistance melting techniques. They usually don't take a long time. If you have a depressed or anxious patient, you can usually melt away the resistance to change in 20-30 minutes of a single therapy session. And once you've done that, the patient's resistance disappears and they become a partner with you in change. And at that point, recovery is generally just a stone's throw away. 10, 15, 30 minutes, you've got a complete elimination of symptoms after that point. Can you help me out here? I mean, there's so many things to say. I just don't know how to go about it.
Just to respond to what they're saying is that, I know they're talking about giving as much power to the client and taking away power from the therapist.
That's what we do, or that's what they do?
Well, that's what JM is commenting on, saying that
that's good or bad.
That's supposed to be good.
Well, that's what we do,
and that's what we do. I think that's what we do because the agenda setting is, as you often say, paradoxical.
Yeah.
And in the paradoxical agenda setting, you're you're not pushing at all. And you're waiting for the client to come to you. And in fact, you kind of retreat a little bit.
Yeah.
Which makes the client notice that, wow, I need to be a partner in this interaction.
Oh, yeah, absolutely.
So they come and seek you out.
Yeah. And you also, the neat thing about it, you bring out all the reasons for them not to change, and reasons that are really very flattering to them, that show the beautiful and awesome thing about them. And TEAM is based on the idea that depression and anxiety do not, in fact, result from what's wrong with you, like a chemical imbalance in your brain or a troubled childhood, but rather depression and anxiety are a manifestation of what's most beautiful and awesome about you, and that there's a lot of strong benefits from your depression, your shame, your hopelessness, your anger, your anxiety. For example, I just to give a simple example of that. I treated a woman at a workshop recently who had, and we've talked about this before, but she had been raped and beaten by her husband for 30 years, 3 decades, finally got divorced, and then had another 12 years of depression before she volunteered in this workshop. Yeah. She had 42 years of failed therapy for depression and anxiety. Yeah. And the positive reframing, the agenda setting, just melted away her resistance and opened her up to just a rapid and profound recovery. But part of it is like, what is good about your symptoms? For example, she was still 100% anxious. But what's great about her anxiety? Why might she want to continue to be anxious?
Well, there's all kinds of reasons. I think we've gone over those over time, but there's the benefit of the anxiety, which is it keeps you vigilant to make sure you don't put yourself into a bad situation again.
Exactly.
This is the protective aspect. And then there's where it emanates from, which is, your own yearning for a better life, the standards you have for yourself.
Oh, yeah, right.
The need for connection. I mean, all those are really, positive things.
Yeah, absolutely. There's only been one variable in the world literature that's been shown to have a large and consistent causal effect on changes in depression in multiple studies, and that's a scale that I developed years ago, and it's evolved, but it's called the willingness scale, and it in simple terms, it tests the patient's motivation. What are they willing to do to get over their depression? Would they do psychotherapy homework, for example? And the scores on that scale have a massive causal effect on recovery from depression. And it's the only...
Have you done a study on that one?
Oh, yeah. I published that multiple. It's been replicated in 5 different studies in inpatient and outpatient settings in top psychology research journals, Journal of Consulting and Clinical Psychology, Cognitive Therapy and Research. I had one in there recently. And other, it's a really validated thing. And there isn't anything else in the world literature. There are a lot of theories about the causes of depression, but all the research studies, they've never confirmed any of the theories except for the role of motivation. But it's a big change because I would have been with Bateman and Edelstein early in my career, and I thought, motivation's not important. It's all cognition. Boy, was I wrong, and boy, has that massively improved clinical treatment and the speed of recovery. It's been the biggest discovery of my career, and I'm just, hope we can do a better job of letting people know how exciting this new discovery is.
Yeah. And so I hope that this answers JM's question. I want to read the epilogue to his to his message. He says, speaking about Dr. Michael Edelstein and Tommy Bateman, he says, I don't think they seem to know as much about TEAM as they claim to. It made me angry that they were dismissing it so flippantly. Maybe you can invite yourself to talk to them on their podcast.
Yeah.
I appreciate your approach to therapy a lot, even if they don't always agree with you. If I don't always agree with you. I have watched every episode of your podcast and find the live therapy sessions especially intriguing. I don't have a lot of hope for myself, though, but that's okay.
Okay.
Maybe we should invite him on the podcast.
Yeah, we'd have him on the podcast. Well, thank you for
or
that.
Her, I don't know.
Or her, this person, whoever. But yeah, thank you for that thoughtful one. And yes, it's sad that we do tend to dismiss things we don't understand well, and we were all these competing schools, and everyone's trying to one up everyone else. But gosh, I love you guys. I've known so many REBT therapists, and I used to go up and speak for Dr. Ellis for his group, and I have nothing but the fondest of memories for Dr. Ellis. And I'm just a big fan of REBT.
Yeah, well, before I knew TEAM, I was also a big fan of REBT.
Oh, yeah.
So. All right, well, thanks, David. That was great.
Okay.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. Theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.